Good afternoon, everyone. I'm Charlie Maloney, president of Shin Imaging Center. I want to welcome everyone today to our MSK and soft tissue injury webinar. This is the second in our series of continuing education webinars. Back in May, we sponsored a webinar on TBI. A recording of that webinar is available through our YouTube and social media pages. Shin Imaging has a long history of sponsoring educational events for the medical and legal communities, and during this COVID period, we'll continue that tradition through these webinars. With that, I'd like to introduce our moderator for today, Tom Farrer. Tom is an award-winning personal injury and product liability trial lawyer. He's the founder of Farrer Law, a trial firm for the people that focuses on catastrophic spine, brain, and orthopedic injuries. Tom has tried over 50 cases and has had multiple seven-figure verdicts. He's been honored for his work as a trial lawyer, receiving CALA's Rising Star in 2018, OCTLA's Young Gun Award in 17, COAC Street Fighter Award in 16, and he has been twice nominated for CALA's Trial Lawyer of the Year. He's a board member of the Brain Society of California, Consumer Attorneys of California, and the Los Angeles Trial Lawyers Charity. With that, take it away, Tom.
Thank you so much, Charlie, and thanks again for putting this on. I think these seminars are just so important, especially this one, because these are the injuries that we see most often in our cases. And so what I'd like to do is introduce our awesome panel today. I'm really excited about this panel. We've got Dr. Cressy. He received his Doctor of Chiropractic degree from Cleveland Chiropractic College, Los Angeles. He also holds a Bachelor of Science in Physical Anthropology from UC Riverside. He's a graduate of the Spine Research Institute of San Diego's Whiplash and Brain Injury Traumatology program, specializing in auto crashes. The foundation of Dr. Cressy's practice is really based on treating people the way he would want to be treated, and making sure that he offers the proper diagnosis and a high standard of care. We also have Dr. Jeffrey Lai, who's a board-certified doctor in family medicine and sports medicine, specializing in non-surgical management of athletes and active individuals of any age. He has medical interests in the musculoskeletal, ultrasound, orthobiologics, sports concussions, and hormone optimization. After graduating medical school from Albert Einstein College of Medicine, Dr. Lai completed residency and fellowship at Long Beach Memorial Medical Center and was the fellowship director in primary care sports medicine. He is the team physician for Long Beach State University and has served as a sideline physician for various sporting organizations, including the NCAA, USA Rugby, USA Gymnastics, USA Women's Water Polo, Run Disney, and the World Series of Volleyball. And last, we have Dr. Corey Chakarun. He is a board-certified radiologist, completed his radiology residency and additional one-year fellowship in musculoskeletal imaging at the University of Southern California. At USC, he was appointed chief resident and named fellow of the year. He has published scientific papers, abstracts, educational exhibits as lead author, and presented findings before international audiences at American Rhodium Race Society and the Radiological Society of North America. His special interests include radiofrequency thermoagulation of bone tumors, I may have butchered that and I apologize, imaging-guided joint injections, imaging-guided biopsies, and imaging of musculoskeletal disorders and sports-related injuries. We're going to start off with Dr. Cressy first. And for those of you that are tuning in the audience, this is an open forum to some extent, so if you have questions, go ahead and submit them, type them in the chat. I'm going to be looking for questions and using those questions to sort of stimulate some discussion with the doctors. So without further ado, Dr. Cressy.
Thank you so much, Tom. Really appreciate that introduction. And it's an honor to work with you and work with all the other doctors and with Shin Imaging. I've worked with them for many years now. They do a great job, and I'm happy to be a part of this presentation today. You know, where my position as a chiropractor falls in when we're looking at working with someone in a med legal forum tends to be that the patient comes in to see me. Often they'll come in to see me first before they see anybody else. I tend to function in the, as a primary care provider. And so what happens is they'll come in and see me, and I have to do the right evaluation and proper treatment. But where it really comes down to is, what is wrong with you? What is going on with you? Not am I going to fix it, but what is wrong with you? And that requires a proper history, examination, and going through the steps to make sure that we don't miss anything. There's certain things that I'm commonly looking for when someone's been involved in a traumatic incident. And that would usually be, I'm checking the spine. I'm checking the spine, and I'm screening for injuries such as disc pathology, problems with a facet joint, or even might even have had a brain trauma, traumatic brain injury, concussion. Other screenings that we do as well is I'll make sure that I screen for orthopedic problems. Now, I know that one of the other doctors on the panel is going to go further into the assessment and the limitations of the extremities. I mostly would say that for this purpose, I'm just going to give you a tease and a little bit of information about how I function to make sure that I medically manage each case properly and get that patient to all the right providers. You know, the way that my job is, I'm working with these injured people, and I'm working with them to make sure that they get the proper diagnosis, but they also see anyone who's going to help them. And I know I'm just one of the many to make sure that they get that place where they're really injured to however much improvement they can achieve during the treatment. So one of the things that I like to do with the patient after I do an examination and come up with some, from my experience, figure out what I think is going on with them. So I go through a little bit of education with them, and that's also where it comes into play, getting the appropriate diagnostic imaging. Some examples of that would be, like, say a patient comes in and they have neck pain and radiating symptoms down into the shoulder. And I'll go through and show them an anatomy app that kind of explains why my suspicion is that something's going on. And then I'll get the proper diagnostics in. I'll do a screening test where I see how the range of motion is. I'm going to check their ranges of motion. I'm going to check for the tension in their muscles. It's not every time are you going to get a radiating symptom from the neck down the shoulder for a disc pathology. Not every time are you going to get numbness and tingling in the leg for a disc pathology. So I'll look for the other subtle signs and findings. I don't want to bore you with all the details, but the examination, I mean, we don't have enough time. Let's face it, we don't have enough time to talk about what goes on in the examination. But the main takeaways are, I'm going to check their ranges of motion. I'm going to do testing to see if I can elicit that pain. And really, I think the best way is to find out, because there's so much limitation with orthopedic testing nowadays, that if you just get empirical evidence through proper imaging with a 3 Tesla MRI, it takes a lot of the guesswork out. So once they get the indication there that I can go ahead and medically order that MRI, you know, I'm looking at ACR guidelines, making sure that we're not stepping out of our lane and making recommendations that aren't founded in medical information. But I'm going ahead and sending them out for MRI studies of the area that I'm interested in. It might be the spine, it might be an extremity, and in some cases, it might even involve concussion workups. So generally for a concussion, I'll go ahead and use something like this. Oh, you can't see it with my filter. This is the ACE, the acute concussion evaluation. And that looks for if they're having any kind of concussion problems, traumatic brain injury, as we like to really call it, to be more specific. And if that's happening, I generally will send them out to the appropriate specialist. I'm going to get them managed by somebody, a neurologist, or somebody in that field who specializes in that area, get their opinion. And often we have challenges getting them in to see these specialists very quickly. And if they're in really bad shape and they're having a lot of symptoms, I'll send them out for a brain MRI, for proper imaging. So if it's the first 72 hours, they may have come from the ER, or they may have had a CT. But the MRI is so much more telling about what's going on, and I'll let the radiologist opine on that more about why that is. But I send out to the specialist for the MRI of the brain, and I also get opinion of the neurologist. And I know that traumatic brain injury is something that needs to be properly managed and followed and watched. And of course, the neurologist is going to check in with them, but I'm going to see them on a day-to-day for the conservative care. And my conservative care generally is going to be going for the first 6 to 8 weeks there, conservative care, before I involve a whole lot of other specialists. But it's always dependent on how severe that problem is. If I send them out and get an MRI and they have disc pathology, that's when a bit of education comes in. I explain that the degree of their injury. I will usually recommend they see a specialist if it's severe enough right away, or if their pain is unbearable, I'll have them see a specialist like a PM&R doctor, or pain management, or even an ortho spine or neurosurgeon if it's really severe. But otherwise, we do conservative care that 4 to 6 weeks, sometimes 6 to 8 weeks before I involve that specialist.
Now, doctor, can I we have just a quick question. I think it ties into what you're talking about right now. Is there a time frame when it's too soon to get imaging done, like an MRI, or too late in your practice?
I like to order them as soon as possible. And I'll tell you, there's a couple of reasons for that. Thank you. That's a great question. If I'm going to be adjusting somebody's neck and they were just in a traumatic injury where they could potentially have a disc sequestered in their neck or compression on the spinal cord, and I could potentially make it worse by my actions, I'd rather not do that. I just don't think that that's a good idea. I think that's really dangerous. So I'd much rather have an MRI come back 100% clean than do something, make a wrong move and work on somebody's neck when we really shouldn't be, in my opinion. So that's generally, I like to get them sooner rather than later. If I suspect any kind of pathology in the neck, be it disc pathology or anything else, cord compression, I'm gonna get that MRI right away as soon as possible. And then what's great about that is then we have the information, and it really sets the tone for what's future for the management of that patient. And I can give them the expectation that you're probably going to resolve in a reasonable amount of time from conservative care versus, this is pretty bad and we may need to get other people to help us down the road if you're not getting good results from this conservative care or physical therapy or acupuncture or anything else conservative. That way we can kind of set the tone and set the expectation. And one of the things I'll do when I'm making those, I'm just doing a little share here. One of the things I like to do for that is I give them a little bit of education on what's going on. So for example, I got an MRI back on this person, and this is an anatomy app. And I'd like to take this and say, hey, you know what? We've got a disc problem here in the neck, and I'll pull it up and I'll show them where the nerves are, and I'll show them where the connective tissue is in there, the disc, and I'll bring it down and I'll show them, hey, this is the problem. Here's the middle of the disc. Here's the outside of the disc. And the MRI shows that you actually, in fact, have a problem right in this area right here. And if you see right there, you have a tear right in part of the disc, and you've got a fluid accumulation. It says on the MRI you have a T2 weighted hyperintensity, which basically says that there's swelling and fluid accumulation there, and it's pressing against the nerve right here. And we can follow that nerve out and see where that pain pathway goes. And I kind of missed the level, but this is a common place where I'll see pain on a patient right down their shoulder blade. And they're saying, "Doc, the pain's over here. It's not really so much in my neck." And this shows me why, when I have that empirical evidence, that MRI to collaborate with where the pain pathway is. And it gives me so much information about what to do for that patient and how to best treat them. Now, I'm not sure if I answered that question about timing, but I generally like to order them early rather than later. Best to know more information early. I don't like to wait 2 to 3 months to find out that there's a sequestration in their neck and that they were surgical the whole time, or that now there's a question, did I cause it? Like, was I part of the problem here? And I don't ever want that to be any question there. So I tend to like to send them out right away if they suspect an MRI is necessary for the neck. There's certain guidelines. You can look for pain on the midline. It doesn't have to be a radiating symptom. So if they have pain on the midline after trauma, or certain acute back spasms, things that are there. There's a whole list of this, and I don't think we have enough time to go through it, but maybe one of the future events that we do, we'll go through ACR guidelines and how that comes into play for this decision making.
What's the name of that app? What's the name of that app that you use?
The app I'm using? This is Complete Anatomy 2020. It's pretty cool. You can actually share, you can record video. I had a video on here of doing an MRI report of findings of one of my patients. I was hoping to share today, but I realized we don't have enough time. And it would run through about like 8 minutes explanation about what was wrong with her disc and how it affected her facet joint and where the pain pathway was, that kind of thing. And it's just such a great tool for education with the patients. You can video it. You can do a lot of things. You can create fractures. You can create bone spurs. You can create, what else? Tumors, things like that. Hopefully we don't have any tumors, but you never know. Just 2 weeks ago, through Shin, I ordered an MRI on a patient who'd been being treated by another doctor. And for whatever reason, they never had ordered an MRI. I mean, there was a huge impact. The person had, the poor lady's dog was ejected from the vehicle, was killed, and it was a huge impact by a semi-truck, and there was no MRIs done. So I ordered the MRI, and of course I found traumatic injuries. But you know what else we found was a pathologic growth on her kidney, and she's going to get surgery next week.
Oh, wow.
And it's stuff like that. Like, I feel compelled to order the appropriate imaging, because what if we're missing something? I mean, that doesn't happen all the time, but it was weird. It happened twice in that time period where we found pathologic problems in the patient, in addition to the injuries that were sustained in the crash. So yeah, our job's pretty cool. What we do, we're helping a lot of people, and I'm gonna go back here and stop the broadcast. You watch out, I didn't mean to show the guns there, but my wife will beat me up for that. But yeah, what we do is so amazing. I'm really happy to be a chiropractor and appropriately manage cases and work with people. History and assessment, making sure I screen for spinal injuries, potential traumatic brain injuries, sending them to the appropriate specialists, getting them out for specialists for orthopedic problems, extremities, educate that patient, get through the conservative care, and then make sure that I continue to stay connected with that patient. And the challenge with that is a lot of doctors are specialists. They're amazing. They're harder to access. We are available. You just call the office and they can get in right away. So if that person has a flare-up, they can get back in. If they have a problem, they can get back in. And now I can send them to the ortho, the neuro, the pain doctor, additional imaging, whatever we need to do. And I have that direct contact with that patient, and I can do the appropriate medical management all along while they're being treated.
You know, Dr. Cressy, is there too much, or I guess the better question is there ever too much chiropractic care or too much conservative care where, you know, this is a patient that shouldn't be undergoing this care for this long? Is there a cutoff, or is there some indicator that lets you know, hey, we should, you know, pump the brakes on this, or this is the best that I can do at this point? What tells you when a patient has had a sufficient amount of conservative care and really should see another specialist?
Well, I think that that's got a couple. It's got a couple parts to that answer. The first thing is just making sure I'm not mirroring stuff. The first thing is that we want to keep a short period of time and then involve others to make sure that we're staying the course on the right course of treatment. Now, if I bring in an orthopedic or a pain specialist somewhere along the way, and they see the options are, well, let's see, this patient could go get a spinal fusion right now, or we should try something conservative for a little while longer, and they make that recommendation for additional conservative care, I'm just going to listen to the medical doctor. If they say I should do it, I should continue doing it. I'm not the kind of guy who's going to sit there and treat a patient for 9 months or a year without involving anybody else. I've got to make sure that we do the best and most effective care. I mean, if you're treating someone 3 times a week for 50 weeks, I mean, that's like insanity. Why isn't it helping them? But on the flip side, some patients are in so much pain, they actually do need some additional management of their pain along the way. And they're not going to go get an epidural every week, but they're in this constant pain, or they'll have a flare-up. Disc pathology has flare-ups. So I listen to the patient. If the patient says they're in pain and they say that what we do is helping them and effective, and it gives them time to pick up their child, or they can go back to their job and do what they weren't able to do for many weeks to months, or they can do other things in their life because of what we're providing, then I'm just going to go ahead and do what I feel is right there. I make sure that I involve other specialists, always. It's important to have them involved. You can't just treat for 6 months, a year, 2 years. That's crazy. But it is reasonable to treat a patient for durations like that if they have other specialists involved and they've made recommendations to do other things and they've followed through and done those other things, and they've been effective to some degree, but they still need some help, or they have a flare-up, something like that. I can see treating them for a longer period of time. People always ask me, like, hey, doc, when are they done? And that's assuming that this is like a black and white on and off switch, and that you just, like, some of these injuries are permanent injuries, and the patient has a permanent injury and they're going to have flare-ups and they're going to have residuals. I can't just say, oh, you're done because the attorney said that it's 3 months and you got to be done. That's not appropriate. I'll treat them medically for whatever's medically necessary, for as long as I need to, as long as it's giving them relief. It's when it doesn't give them relief, it makes them worse, or we're seeing other problems manifesting, that we don't do that anymore and we try something else, and we may just give up for a little while. I know I've worked with some of the pain doctors where we'll actually give it, 30 to 60 days break just to see if no chiropractic, the shot was done a while before that, no chiropractic care, getting them back on their exercise program and trying to return back to their life without any help, if they're able to do it. Some of them can and some of them can't. And I just do the best for my patient.
Awesome. Well, thank you, Dr. Cressy. I think we're going to turn it over to Dr. Lai.
Hi, everyone. That was fantastic. So just to build on that a little bit, as a sports medicine physician, my office is really in 2 different locations. One is, I've got a regular clinic office, but the other part of what I do is that I'm on the sidelines. So what that gives me the benefit of is when these injuries happen, I can be there and I can see it unfold. And so that's going to be one of the themes for my talk, which is what would I advise you as a clinician to kind of want to put together? We all want to treat patients. We want to come up with the appropriate plan, the appropriate therapeutic plan for them. And for me, it's a triad of three things. One is, the history has to make sense. The mechanism of injury, whether it's, in my realm, it's sports, so slide tackle, contact versus non-contact. The history has to be something where you're getting some hints from what the athlete is telling you to match that with the injury that you're suspecting. Second is really the importance of the physical exam, specifically the musculoskeletal exam. And I'm going to give you some pearls in terms of some limitations and just the trends that I'm seeing with the physical exam. And then third and foremost, and most relevant to this talk, is just the type of supporting imaging that you as a clinician are going to order. And that can start from the basic things like plain films, but obviously a big topic and the big resource that we have to rely on, as Dr. Cressy mentioned, is advanced imaging with an MRI. So here's, this is like I said, this is my second office. So a lot of times sports medicine physicians, we're just kind of in the background. It's usually a good day when we don't have to be called into action. Another sideline photo. I cover a lot of rugby. That's one of my medical and sports medicine interests. So a lot of injuries there. So we were talking about the mechanism, and this is obviously an obvious one. With sports medicine, I have the luxury of there being a lot of photography, a lot of video at place. But sometimes it's pretty obvious when the injury happens, what's going on. So when we talk about the musculoskeletal exam, which I'm going to dive into, there's so many exam maneuvers, and there's so many body parts that we can cover. But overall, the overarching themes in terms of how you're going to conduct a physical exam is going to be pretty consistent. Number one, it's always going to start with inspection. And in inspection, you're looking for swelling, you're looking for deformity, you're looking for redness, you're looking for bleeding, breaks in the skin. Second, you're going to do some palpation, and I'll have some cases where I'm going to show you, you might not want to palpate as much as the textbooks tell you to palpate. After that, you want to assess the range of motion, and the way that I do it, I usually start with active range of motion. If the athlete can give me a few degrees, I'm usually not going to push it beyond that. If they can give me a full motion, then I usually don't have to passively range them. And then there's a whole host of special tests that every body part has, whether it's the shoulder, whether it's the hip, whether it's the knee, whether it's the ankle. And that really is just additional tools in a clinician's arsenal. And that's generally what I teach. I teach to medical students, I teach to residents, I teach to fellows, just the importance of the musculoskeletal exam. But what is the big, the trend that I'm seeing with the MSK exam is that it's really a dying art. And you can say that it's kind of like, landlines, or it's kind of like the stick shift, where there's just fewer and fewer and less emphasis on this. And if you get into the reasons why, there's a lot of reasons. I've boiled it down to three things. One is that the MSK exam is really operator dependent. The more that you do, the better you're going to get at it. And the less that you do, the less you'll get at it. And I've certainly put in my 10,000 hours of doing exams on all MSK joints and extremity body parts. And there are still things that I will miss and that I cannot completely rely on my exam to uncover. The other part is that the exam is going to be very patient, or in some cases, just situation dependent. And what I mean by that, I'll show you a picture here. Give me a second, I'll show up some of those pictures. But sometimes you just can't get the exam that you want, partly because of how fresh, the acuity or the severity of the injury. And as I mentioned, with me being a sideline physician, a lot of times I'm not gonna push with a fresh injury. Case in point, a very swollen knee, where there's just a massive effusion after, let's say, a slide tackle or a non-contact injury. And if I'm suspecting a torn ACL or a really severe multiligamentous disease, then I'm not going to really push on an exam. And I'll give you a picture of that in a second. So here you can see an example of just a knee that I'm not going to push too hard on. It's the left knee for this patient. She's a young girl who was playing soccer and had a slide tackle injury. Really, this is going to be a very minimal exam, and I'm already suspecting, it's a pretty significant internal derangement, possibly some bony injury, and so I'm going to advance my next step in my plan to imaging. Okay, and obviously for her, she came in, she was being assisted by her family. She didn't really want to weight bear, very limited range of motion. This is another example. This is a volleyball player, an outside hitter, who went up for a block. The ball went off of his hand. With a swollen thumb area like this, I'm, an extremely tender. This was probably half an hour right after the injury happened. I'm not going to push too hard on this. There's some things on inspection that I can get. If you look on this side, you can see a little bit of bruising right around that metacarpal phalangeal joint. That was really what I isolated.
Can I stop you for just a moment, doctor? Are you looking at the image 07, the knee effusion?
Oh no, I moved on to 9.
I think you may be sharing just the windows that has all the different images.
Let me try this.
There we go.
All right. Apologies. Are you able to see number 8 versus number 9?
Oh, wow.
Okay. So this one, this helps me isolate that exam a little bit more, and I see bruising. And this athlete ended up having a complete avulsion of his radial collateral ligament around that MCP, where essentially his thumb was essentially just unstable in terms of the valgus and the varus movement. And within a couple of days, he was in to see the hand surgeon for a surgical correction of that. Now, sometimes also the importance of the inspection is really key. This was a bodybuilder who came and saw me for right shoulder pain, and it had been progressive over the last 6 months, but still able to do his sets, but just markedly weak after that. And again, just in terms of the inspection, his range of motion was great. His strength was a little bit weak, but as soon as I asked him to take off his shirt and looked at him from behind, you can see marked atrophy of the supraspinatus muscle and the infraspinatus muscle. And without any sort of trauma or injury that he was talking about from a history side, this is where we decided that, I did get advanced imaging on him, and he ended up to have a fairly rare condition or less common condition called Parsonage-Turner syndrome, which affected the brachial plexus nerves that were supplying 2 of those rotator cuff muscles. And that's what was contributing to his weakness. Again, it's subjective weakness. This was a very strong guy, but he was just weak relative to what he normally does. But still, I would say he was at baseline much stronger than I am.
That's actually a really important point that you bring up. That here's this guy who's a strong guy. He's lifting weights, and most people live with some type of pain or discomfort, but they still do their activities. They still work out, or they still, put on, if they've got an ankle that's sore, a knee that's sore, and they're going out, they may wear heels. And so a lot of these injuries don't necessarily stop people from doing things, but they change the experience people have doing things. And so when you're examining a patient during these musculoskeletal exams, or when you're meeting a patient or following up, do you try to educate them that it's not necessarily that you can't do something, but is whatever injury or symptom you're talking about, does it have a certain effect on the experiences that you're having?
Yeah, absolutely. I think, instead of just advising rest or a complete shutdown, the adage for a sports medicine physician is relative rest. And so that's just kind of notching down the intensity, the severity, the frequency, but still encouraging that activity if we don't think it's going to cause additional pain or additional damage. The worst thing to do is if it's the type of condition where pulling on that ligament, pulling on that tendon, or ranging that joint is going to cause more damage, then that's usually where I'll be a little bit more restrictive. But I'll tell you, most sports medicine physicians, we just hate to restrict people because we know that motion, except for fractures, motion in general across a body part is going to be a good idea. It's going to accelerate healing.
I think, and I really appreciate you saying that, Dr. Lai, because one of the things that talking to a lot of injury attorneys that represent people that have been victims of trauma, myself included, we start to get scared or worried because the patient or the client is continuing to do things, albeit at a much reduced level or magnitude. And really it's a big part of the healing process and also preventing further injury to maintain some level of activity despite having an injury. I mean, if you have back pain or if you have neck pain, you should still try to do what you can without, making it worse.
Yeah, absolutely. Gentle range of motion is always good. I was going to jump into some of the imaging modalities that I'll always consider. And I know, certainly MRI is going to be the gold standard. Depending on what insurance environment that I'm in, sometimes I'm just forced to do a plain film, even if I don't think that the plain film is going to produce any meaningful results. This is one example of a plain film that certainly clinched the diagnosis right here with a humerus fracture. This was also a rugby player who went up to go up for a challenge on a ball and landed awkwardly on his arm. And as usual, the radiologist will always say that the arrow points to the pathology. Other things that I have at my disposal when I'm thinking about imaging besides the plain film, which is it's good for bony abnormalities, it's good for malalignments, it's good for alignment in general. But the other thing that I have access to is ultrasound, and musculoskeletal ultrasound is something that you can use, but on a limited basis, really. It's very operator dependent, and it's really only going to be good for very superficial structures. So in this case, this is an ultrasound of a foot. The foot, if I'm looking at ligaments or just the bone surfaces, it gives me a peek of what's under the skin. But if you'll notice, there's just so much dark area underneath that bone that the ultrasound is just not going to give me any access to. This is the ultrasound of the knee, which is a decent look at the patellar tendon with a little bit of fluid under there. But again, it's just going to be limited, and all of a sudden you lose a lot of, you won't get any sort of detail underneath the bone. And then ultimately we get to MRI, which is kind of, what I rely on a lot. And just my pearl on ordering MRIs, just in the few minutes that I have left, there's MRIs and then there's MR arthrograms that I'll order. And the arthrograms, I reserve that for certain pathology that I'm specifically evaluating, such as a shoulder labrum, a hip labrum. Sometimes in the knee, it'll be useful to do an arthrogram if you've had prior surgery, especially to the meniscus. But the arthrogram is where you essentially do the MRI, but you have the added benefit of putting in some contrast into the joint ahead of time. And that will really light up and give a better background for some of the pathology. I just have, three real quick cases to go through that I wanted to show you where MRI was really useful for me. This was a soccer player who came in, and she had knee pain. It was mostly lateral sided, but it was also just very diffuse. And her history was just not very conclusive. Didn't really remember a specific injury, but ultimately got to the point where after practicing, she was limping. So the exam wasn't really telling me much. I thought maybe there might be some wear and tear in the lateral meniscus, but there was also some kneecap related pain as well. So ultimately the MRI really clinched it. It showed that the meniscus was very intact, didn't have any tears, but there was a large chondral fissure, the cartilage, that measured 4 to 5 millimeters, plus some bone marrow edema. And so this athlete ultimately went to have surgery about a month after this injury. This was a case where another soccer player who came in, kind of the similar story with just, a history that didn't sound very convincing of an acute injury, and an exam that just showed a little bit of what we call a positive Lockman's. That means that the ACL might be stretched out a little bit, but otherwise pretty reassuring. And with her ACL was, the ACL exam was the same on the other side. So I didn't think that it was anything terribly specific. So we got the MRI, and it ultimately showed us that she had a partial ACL tear. So there are still fibers that were keeping that structure in place, but maybe making the knee a little bit looser. And after much discussion, we talked about the options. She opted to continue playing that season. She finished the season with some rehab. And then the next season, unfortunately, lightning struck and her ACL. She tore it during a game and then ultimately had to have it fixed surgically. But at least we saved her some time and saved her that second season. This is just a case where, again, this was the case with that swollen knee. And this MRI is ultimately what pointed us to the pathology. I mean, with a swollen knee, there's so many things that we can be thinking about clinically, whether it's the ACL, whether it's a severe meniscal tear, whether it's a kneecap dislocation. And in this case, with this bone marrow edema on the lateral femoral condyle, and there are some other slides that just pointed to the kneecap sliding out of place and then spontaneously reducing, but not before it caused significant damage. So this athlete opted for non-surgical care, pretty much non-weight bearing for 4 to 6 weeks. And then we progressed him after that. So he did well and returned, or excuse me, she did well and returned to her sport. So I think I would just end it up right there. And I think the main kind of pearl that I wanted to leave everybody with is just the importance of matching the history with the exam and the imaging. And when things aren't obvious, that's why, in this day and age, we have access to advanced imaging that really gives us clear-cut views of the pathology, which we're really grateful for. On the sports medicine side too, it really is a blessing to work with certain sports organizations that have access to quick advanced imaging so that we don't have to suffer any delay of care for these athletes that I take care of.
Thank you, Dr. Lai. Just some couple questions from the audience. You talked about mechanism of injury, and when you're on the sidelines, you get the benefit of seeing a player and how they got injured. Whether it was something where it was a non-contact injury or maybe it was a contact injury. But in terms of mechanism of injury, we see car crashes are probably the #1 trauma that causes injury to our clients. And in particular, the most vulnerable body part that we see, or the body part that's most often complained about, is the spine, either the cervical or the lumbar. But we also see cases where somebody's in a car crash, might be big, might be small, might be in between, and they've got wrist problems all of a sudden, or they've got knee problems all of a sudden, or they've got a shoulder impingement, a shoulder problem. I mean, is there a mechanism of injury in car crashes for these other body parts like wrist, knee, shoulders?
Yeah, I always think of those parts as the the innocent bystanders that just go along for the ride. And usually when I see that, it's kind of like a bracing mechanism, especially if you're talking about high velocity impacts. I would say I generally see them more in the context of patient has had an accident a year ago, 2 years ago, gotten the main pathology, the main trauma kind of more or less fixed. And then they come to me and say, yeah, you know, ever since that accident, you know, my shoulder just hasn't been the same, or my wrist hasn't been the same. And, you know, by then people's memories are a little bit off. And I always just, you know, attribute it to just some sort of supporting, you know, support, especially with the wrist, you know, falling on an outstretched wrist or using your hand to brace yourself. I'll see a knee where it gets bruised on either the ground or a part of the car. But yeah, you can see that. But by then, you know, we really don't see as much of the acute injuries, and it becomes more of a chronic injury type of picture.
And, you know, you talked about history as being so important and matching up the history with the exam, with the imaging and the symptoms. And so you have that clinical correlation. Is there ever a time where, you know, the trauma, the onset of trauma happens and it's just too remote, you know, say, is there a time period where the onset of symptoms is just too long or too remote to relate back to a specific trauma? Like if a person said, you know, last year I picked up a box wrong, or I mean, just as a doctor evaluating these patients, where you say, okay, you know, you're giving me a history, but it's not from that event that you're talking about. It's probably something else.
Yeah, when you have that, when you don't have as kind of as much confidence in the temporal nature of the history, then yeah, absolutely, it's tougher. That's when you got to play the sleuth. You're playing the detective, and you're making kind of educated guesses whether you think that there's a cause and effect there. But it is more challenging the longer that initial event was. Absolutely.
Okay.
In cases like this is where I'll say, I mean, the MRI pretty much trumps everything, and any pathology that you find on MRI, that's what we will try to make sense of and tie back to the injury mechanism.
And if you don't see anything acute on the MRI, then what are you left with? I mean, because you don't always see that, especially with spine cases. You know, it's long-standing degeneration.
Yeah.
You don't have two MRIs to compare. So when you don't have anything acute on there as a clinician, what do you do?
Yeah, I mean, spine is certainly challenging because there is such a huge category of that is just chronic and multifactorial. It's difficult.
Got it. All right. Well, thank you, Dr. Lai. We're going to turn it over to Dr. Chakra.